everyone. For those that don't know me, I'm Nicole Carney from Hunter, New England at the John Hunter. So tonight we've got the New South Wales Society of Nuclear Medicine Scientists AGM, which won't take very long. And then we've got a couple of presentations as well. I think we'll do do you need the computer? Do you need the computer for the president's room? Okay. And then our presentations today are from Kirk Rostrom and Dr. Adi Ayula. So we'll start with the New South Wales Society AGM, and I'd like to introduce Adrian Rowe from Global Medical Solutions. He's the president.
Thanks, Nicole. Can everyone hear me okay? All right, let me just get out of this. Firstly, I'd like to welcome you all this evening and thank you very much for coming. And in particular, I'd like to acknowledge the University of Newcastle. Thank you so much for allowing us to come and hold the meeting here tonight. To the guys from Newcastle, John Hunter, thank you so much for all your organising and help this evening. And also, we need to acknowledge our sponsors tonight, ANSTO. I think James Lee is here from ANSTO, so if we could give James a round of applause and thank ANSTO for tonight. Okay, so first and foremost for tonight's AGM, we've got a couple of apologies. Sue Meikle, Peter Kench and Melissa can't be here. You should have all seen the attendance note out the front. Has everybody had a chance to sign the attendance for this evening and grab your CPD certificates? If not, out the front, just opposite where we had the food, there's a large table there, so it should have all the documents there. Sue's away this evening, but she's sent us through the Treasurer's report for 2016. Essentially, the Society's in a good position. The opening balance for our cheque account was $2,463, with receipts of $3,703, disbursements of $1,214, taking the balance up to $4,952. The term deposit is at a healthy balance of $8,407, and with interest has increased to $8,585. So I need somebody to accept the Treasurer's report, and also somebody to second the report. If I could have somebody, Daphne and Nicole. Okay. So I'll just read out the President's report. So as Acting President, I would like to welcome everybody to the New South Wales Society of Nuclear Medicine Scientists AGM, and thank you all for coming. Again, I'd like to acknowledge ANSTO and thank you for your support tonight, and likewise to thank all of the other vendors who sponsored the meetings over the last 12 months. They obviously help us to fund the meals and to put on the meetings, so we appreciate all of their support. In 2016, we had 4 meetings. Prince of Wales, which was on paediatric renal imaging, was sponsored by Siemens. August, it was at Westmead Hospital on cardiac amyloid imaging, sponsored by Landauer. In September, we had the Hunter Technologist meeting, and then November, Raw North Shore, the Explorer PET scanner. These meetings were generously sponsored by GMS, Radfarm, Siemens, Landauer and Clarity. And in 2017, there'll be another 2 more meetings, with the next meeting to be held in July, I think it was the 19th. At this stage, the venue is to be determined, and then there'll be another meeting on the 18th of October. The New South Wales website has been upgraded and now includes member logins. So if everybody could log in and just make sure you can get through with your passwords, and if you've got any issues, please contact us. This year we'll be holding the Radfarm Award again at the Hunter Tech meeting. So for any entries, please let us know. Have we got a deadline for the meeting, for the entries?
The 9th of September, so the deadline will be the week before.
So about the 1st of September. Okay. Once again, financially the Society is in a solid position with the term deposit increasing to $8,585, as I showed a moment ago. Membership is up from 111 this time last year. The membership fees allow us to host these meetings 3 times a year, making up the difference in costs not covered by sponsorship. The Facebook site will continue to feature news and announcements with regard to upcoming meetings, jobs, etc. Please feel free to post or contact the committee, and we'll be sure to include your content. If anyone wants to write something for the CPD section, please feel free to email us, and you'll earn CPD points as well. We welcome any new volunteers to the committee. It's obviously a hard job for everybody to be on the committee year in, year out, so if anybody's keen to join and contribute, please let us know, and we'd be happy to have you. That's it. So I just need somebody to accept the President's report. Okay, got Margaret, and someone to second it. Belinda. Okay. Have we got any business without notice for this evening? No. Okay, so with that, I think that's it. So that concludes the AGM. Again, come and see us later if you'd like to help contribute to the New South Wales Society, or if you want to volunteer somebody else, that'd be even better. That'd be great. So without further ado, I'd like to introduce Dr. Ayula, who's going to talk to us about radium-223. Actually, I think Kirk's going to go first. Okay, so Kirk's going to talk to us first about the use of Lasix in gallium PSMA.
Thanks, Adrian. So hi everyone, for those of you who don't know me, I'm Kirk. I work at the John Hunter and the Mater. So today I'll be speaking about gallium-68 PSMA, PET-CT, and how we use diuresis in our department. Thanks to the sponsors and for the uni for organising this, and Nicole, thanks for roping me into this. So hopefully I don't bore you too much. Alright, so basically just a quick overview. Gallium-68 PSMA, prostate-specific membrane antigen, which is an overexpression allows targeting of prostate mets using gallium-68 PSMA labelled ligands. So it's a type 2 membrane glycoprotein, and it's useful in the staging and restaging after biochemical recurrence in patients with primary and biochemical recurrence. So obviously prostate cancer is a very common cancer in men, and it's the third most common cause of cancer-related death. So obviously early detection is crucial, and for a long time it's been limited to just CT and MRI, which is basically just your size. Now these stats I have here out of Germany because this is part of a journal review that I did, and so 50% have METs after radical prostatectomy and radiation therapy. So evidence in use. So PSMA is significantly elevated expression in prostate cancer cells compared to benign tissue. So it clearly improves lymph node detection, and even when low PSA levels are present. So it's a superior agent than MDP to detect bone mets, and that's a key aspect of this talk. So basically the PSA test is actually really good at indicating what's happening in the terms of metastatic spread, and bone scans are only really picking up very high levels of PSA when bone mets are quite progressed. Obviously, everything with nuclear medicine, there's some artefacts and pitfalls. So radiation dose, of course, to sensitive glands as well as the whole body. And the differentiated disease loses PSMA expression. And now we know that it's not just completely specific to prostate cancer, has been shown in some hard-bodied tumours. So synthesis, we use gallium-68 PSMA HBEB, and we use the ITG manual synthesis system. Our dose to patients is around about 120, 130 odd, but depends on the yield that we have. We try to scan at 45 minutes post-injection, and we're usually pretty close to that, but up to around about 60 minutes. We do 2-minute bed positions, but with 4-minute beds over the prostate and pelvis bed. So the protocol that we've been using lately was IV Lasix at 25 minutes post-injection, but more importantly 20 minutes before they go on the scanner. So obviously if you're running a bit late or it's going to be 60 minutes before you start the scan, you want 20 minutes before the scan starts. Our Lasix dose is usually 20 milligrams, but there has been a range used between 5 and 40, or none at all. So for anyone that hasn't seen the generator, the ITG, so basically similar to your Techie Molly generator, and so you have to install a fluidic system and you synthesise with the PSMA and the peptides in situ, and then get your labelled product. So Lasix, we're probably all familiar with that. We have been using it in MAG3s for a long time, obviously. It's a potent diuretic. Onset is quite quick, so but you do need to be aware that it does last for up to 2 hours, with the peak effectiveness around about 30 minutes. Okay, and we have had some side effects when it was given too rapidly, and so you can get tinnitus and deafness, and also generalised dehydration, so you have to be careful. Often these people can't void well, and so they need to be hydrated well, and so often they're resistant to that. So in our practice, what have we been doing? We've been using lots of different methods. Lots of different reasons for that. Sometimes we give no Lasix. Sometimes we're using the Lasix at 20 minutes before the scan. Sometimes we do a repeat scan only when needed with Lasix. Our Lasix dose has been between 5 and 40, and technique is modified for very different reasons, dependent on the patient, what they've had surgically, what their urine continence is like, and for comfort or just discretion in general. So basically, we've been doing this for a few years now, and so I'm going to call it the Sandeep protocol. So Sandeep Gupta, one of our doctors, brought in this practice of giving the Lasix, so in about 2015, I think. So we decided to do a retrospective study and look at the data and pull out the ones that we wanted. So as I mentioned before, giving the IV Lasix is approximately 25 minutes post-injection, but 20 minutes before the scan. Giving a dose of 20 milligrams, and this imaging protocol of 2 and 4 minute beds. So this would hopefully negate the need for any repeat images, with a dose of around about 120 mg. So the hypothesis was that Lasix dilates urine but does not affect the physiological binding. That would improve the differentiation of disease, and we could differentiate the urine from bladder and ureters, and we could better detect nodes and disease. Now, there was a thought that we needed to give Lasix after sufficient uptake time of gallium-68 PSMA, because at this time there was no research, no papers out with the use of Lasix in PSMA. So we weren't 100% sure what happened, so we wanted to make sure there was significant uptake time before we gave the Lasix. So the aim, and this is a poster that will be at the NSWSNMS conference, so to assess impact of routine use of intravenous furosemide prior to scan on urinary tract activity and on scan interpretation. So the method, basically we got the group of patients, split them into two groups. Group A without furosemide and Group B with 10 or 20 milligrams of furosemide. So we got rid of the outliers of the 5 and the 40 and concentrated on what we originally hoped to use. So those various quantitative and qualitative measures were compared. So again, sorry about the wordy slides, but basically what we want to look at here in the Group A, which is without Lasix, the SUV max of the bladder was around 50 and the ureters around 6, so quite high. And then in comparison to the Group B patients, which were with Lasix, and were substantially lower at 10 and 2 respectively. Now the key point here is that also SUV maxes were calculated in the liver to demonstrate that there was no effect of furosemide on organ uptake, and therefore we can say tumour uptake. So, and they were similar between both groups, so with and without were around about the 6. So the review was by a single physician who found 50% of studies of Group A had significant urinary activities leading to difficulty in interpretation. So compared to 0 in Group B, so pretty significant findings. So what does that all mean? Now, on your left-hand side you have A and C, and they're the same patient. Patient B is different. So just looking at patient A, you see a concentrated very hot, high SUV bladder at A, with a focus just proximal to the bladder. Now, at first look, this looks like it could be in the prostate bed. Now, image C is actually a repeat image with Lasix. So the first image A was without and C with. And you can see that there's a very dilute bladder, and that intense part that looks like it's in the prostate has now resolved. So looking at group B, now this is how we'd like to image him, and this is how we used it for the study, was Lasix at 20 minutes prior to scan. And as you can see, a very dilute bladder, low SUV, and a very intense uptake in the prostate bed. So you can confidently say that this is PSMA avidity. So in conclusion, routine intravenous furosemide during gallium-68 PSMA leads to significant reduction in the urinary tract tracer activity and improves the scan interpretation without affecting quality. So just in a quick summary, we've been able to, by a simple process of giving a drug that's well tolerated and well known in literature, we've been able to increase confidence in reporting, we've improved visualisation, we've decreased bladder and ureter activity, but we've demonstrated that tumour and organ uptake remains the same. Radiation dose has been decreased. Now, in saying that, there's two parts to that. Obviously, we've negated the need for repeat images, so less radiation dose to the patient, and also because we're not re-scanning and not getting them back on the bed to the technologist as well. So we've increased throughput as well. So sorry that was a bit rushed, but that's basically the essence of the poster that we've done and the research that was done in-house. So just to re-emphasise that point, I'll follow it up now with a case study, which is a bit of a rare case. So original presentation of a 74-year-old gentleman with a total prostatectomy and with rising PSA. So basically, we haven't seen any METs in any imaging, and they're querying where is this rising PSA coming from. So even after total removal, radiation therapy and hormone. So original images. So sorry about what images I have, but if you have a look here, it looks like some ureter activity and some hold up there. Now if I can get this to play, you can see there is some actual other ones up a bit higher which are tucked in behind the bowel here. So there was found to be some low-grade foci of PSMA activity in line with the ureters, and that was classified as urine, so which all fitted with fusion with the CT. So therefore no scan evidence of metastases. So the report, as I said, showed no METs, was re-reviewed and by 3 different physicians who all found that there was urine activity present, but addendum was added for a possible bone MET. So after comparison with CT and bone scan, there is uptake in the lumbar spine, which is PSMA avid, so it could suggest pathological fracture. So 2 years later, they have an MRI which did not concur, so nothing had been done over the 2 years. So represents for another PSMA scan with us. Gleason score 7, PSA now 12.3, and no change in staging criteria. So there's still the suspicion of METs. What's going on here? So repeat. Now this, sorry, I forgot to mention, the first image was done without the use of Lasix because it was before we did the Lasix protocol. So this patient was done one scan only with Lasix, and as you can see, 3 avid areas of nodal involvement in the right common iliac and internal iliac regions. Okay. So the report, sorry again a bit wordy, but I'll just summarise as we saw those 3 nodes that are avid. Now it was mentioned that it was compared with the 2015 study, and they were actually there originally. Now, however, that was low-grade activity and was called as ureter uptake. And if you follow down through the CT, it does make sense. It's low-grade, and it was seen to be urine at the time. But now, with the use of Lasix, we can say that they are still in the same nodes. They have now got hotter, of course, and we can say now without doubt that it is actual metastatic spread. So there's the two in comparison, and you can see on the left-hand side the ureter, this was actually ureter here and this cleared, and as you'll see in some other slices shortly, that there was some actual other ureteric activity which is cleared, and then so this is here, and there's also some low-grade activity here. So it's worth noting too that there's a very intense uptake of bladder without the Lasix, and then a more dilute enlarged bladder. So just some extra grabs of that comparison with 2017 on top, and I have truncated these a bit more so you can see them. And so obviously some faint nodal activity here, which is in line with the ureter, but it's just adjacent in hindsight. Okay. Again, just another grab of that, and you can see in the CT that there is a little nodal bed there, and that it was hot in both times, although I have truncated it more for the 2015. So just running through a fused axial as well, just for another way to look at it. Truncated up, so if you go down past the kidneys here, you can follow it down and you see there's long lines of what looks like ureteric activity. So you can't begrudge any reporting physician for that. It did follow, did make sense, and it was not exactly clear. So in 2017 with the repeat with the Lasix, you'll see once we pass the kidneys there's no ureter hold up, and there's just some nice hot little nodes there as we come down. So this is a rare case because it demonstrates the benefit of the use of Lasix as a misdiagnosis, and we can say now without doubt that Lasix washout does aid in diagnosis. It also is a benefit because it's the same patient with and without Lasix. Obviously in any study the best idea would be to scan them 2 days, one with Lasix, one without, but due to radiation purposes and time on the camera and cost, we can't do that in a real world. So moving on from this now, as I said, this research started a couple of years ago, and so recently we have changed our departmental protocol, and all doctors are now giving Lasix at time 0. The scan is still at 45 to 60 minutes, same imaging protocol, and usually a dose of 20 milligrams is given. Now it's usually 10 or 20, I suppose, but it does depend on what is actually happening pathologically with the patient and what their continence is and comfort and etc. So all patients are interviewed beforehand, and we've seen that there's been a lot better patient tolerance after the 45-minute washout, as a lot of patients early on were having that peak drainage at around 30 minutes, which is exactly when they were on the bed, and so it saved having to get a bottle in place at short notice. So just another quick screen grab to show the benefit of it. Obviously on the left you got no Lasix, a lot of hold up there and a very intense hot bladder. You can't see anything around there, you can't differentiate prostate bed to bladder. And then one with Lasix, even though it is a enlarged bladder, often they're not like that, but you can clearly see anything tucked in behind. So that's it, and just a special thanks to Sandeep for his hard work and all the techs that helped, Liz, Kev, Tani, Scott and all the other techs who have ever had to hold a bottle while the scan's going. Thank you.
Any questions at all for Kirk? Yeah.
I don't know much about PSMA, so excuse my ignorance if I'm asking the wrong question. But if you're using Lasix to get rid of urethral activity and the bladder, or reduces bladder. What about the bowel activity? That's bowel, isn't it?
Yeah. So there is a lot of bowel activity. There's another study ongoing with Tani, and she's doing a fasting protocol. And so where there's benefit in that, you might want to talk to her about that. But yes, that is also one of the downfalls with it. But I guess those nodal chains follow very closely to the arteries and the ureter, and so it's very important to clear up that part near it. But there is also the downfall of bowel activity.
Kirk, you mentioned that some of the doses had been reduced to staff from not having to get in and then rescan the patient. Have you done any quantitation on how much the doses have been reduced to staff at all?
No, we haven't. We don't do heaps of PSMAs. Obviously, we do a few a week, but it's just what does count is that we don't have to repeat them, and it also works better for our workflow. Yeah. And but yeah, so more so, I was talking more about the patient dose, but there is obviously less time spent with the patient, bringing them back and forth, getting them on, holding bottles and whatnot. So.
Thank you.
Thank you.
Just as a little thank you to Kirk, thank you very much for presenting. That was very interesting. So next up I'd like to welcome Dr. Adi Ayula, who's going to talk to us about radium-223.
Yeah, thank you very much for having me here today. Thank you, Nicole, for getting me to do this talk. So my background is oncology training. I'm a medical oncologist, currently working in nuclear medicine. So my talk today probably will have a very strong medical oncology bias. And I have to say, I actually didn't have any chat with Kirk before the talk today. And I realized that there's a very strong prostate cancer bias. So just a brief outline, just a quick run through about what a prostate gland is, a brief overview of prostate cancer, what we currently do in terms of treatment options. And I'll mention just a quick history of radium and some randomized phase 3 data on radium-223, how it pertains to management of patients with prostate cancer. And a quick case study, and from the initial phase 3 data, what other potential hypotheses has been generated, and future directions. So, as we all know, prostate gland is a male accessory organ, and it's one of the prostate cancer is the most common male cancer. So the main function of the prostate gland is it's an accessory sex gland, which helps in some seminal fluid production. It's normally arranged in a well-defined axoni, and there are interspersed in between them neuroendocrine cells, which in some cases could give rise to a particular variant of aggressive prostate cancer. Now, interestingly, Australia and New Zealand actually have one of the highest, well, I think the highest incidence of prostate cancer in the world. About 1 in 4 of all male cancer diagnoses is prostate cancer. And in 2016, this accounted for about 12.8% mortality. Now, the good thing about prostate cancer in the very early stages, or the low-grade disease, is there is a 94% chance of a 5-year survival. Now, in terms of treatment landscape, Now, most patients will start their journey right around here, where they're initially diagnosed with an early stage disease. Now, with early stage disease, they have a local therapy, which is either surgery or radiation. And then over time, they have what we call biochemical relapse, and that's where PSMA, PET-CT, is actually really coming into place now. And one of the options of treatment at that time is more local therapy, either in the form of salvage radiation treatment or surgery. Now, for those who are unable to have local therapy or who progress beyond that, we then begin this process of hormonal manipulation, what I describe to my patients as inducing male menopause. Now, in terms of what options we have for androgen deprivation, over the past, shall I say, 5 years, there's been quite a lot of medications coming out, making it onto the mainstream market to assist us with this. So the basic principle behind that is either we target the androgen receptors that the prostate cancer cells rely on, or we block the pituitary control of androgen production. Now, the main thing to realize here is that this particular green bar of alpharadine is actually radium-223, and there was some strong clinical evidence, which was published back in 2014, about its usefulness in patients with advanced prostate cancer. Now, unfortunately, once this process starts, most patients are not cured, and progressing from these points up to this point could be quite variable. In some people, it could be less than 2 years, while in some, they could still be going for 15 years. So it's quite variable. And one other interesting thing we're beginning to get scientific evidence for is when most drug trials are done, they're usually done towards the end of that curve. And once there are benefits demonstrated, the rationale is we now then start looking that what about if we treat these patients earlier with these medications? Do they actually derive more benefits? A few years ago, so docetaxel, which is one of the chemotherapy we give, in a very resistant metastatic state, we actually realized that following a phase 3 study that if we gave docetaxel very early on, before they developed resistance, people actually did better. So now there are ongoing studies looking at giving, abiraterone or enzalutamide earlier on in the disease to see the, if we actually have an improvement in clinical outcome. Now, radium is not a new earth metal or radioisotope. So I've got lots of wordy slides, but I'll just try to give a brief summary of them. So discovered back in 1898 by Marie Curie and Pierre Curie in a uranium mine. And the name radium comes from the Latin word radius or ray, and that was in recognition of radium's power of emitting energy in form of rays. Now, at the time of the initial discovery, radium was like the magic bullet, and within a very short time, it made its way to literally every single aspect of societal life. If you had a product and you wanted it to make it to mainstream markets and become a bestseller, all you have to do is stick something radium on it, and bang, people start buying. So it found uses in watches, instrument dials, toothpaste, hair creams, and even some food items. had radium in them. Now, part of the attraction was that people realized very early on that there was some medical benefits from using radium. So one of the things was that people noticed was that people that had skin lesions could use radium paste, and that will result in a shrinkage of the skin lesions. Now, Howard Atwood Kelly, a renowned founding father of Johns Hopkins Hospital, was one of the first people who used radium in treatment of cancer, and he devised a means of what we call brachytherapy today, basically getting the radium within the body cavity close to the cancer cells so that you could emit energy that resulted in cell death. Now, one of the patients that was treated, for anybody who's done lab research, is Henrietta Lacks, who was diagnosed with cervical cancer, and records show that she is the origin of the HeLa cells that's used in lots of laboratory research. Now, I just got some of these interesting captions from the internet, just to show how popular radium was back in the early 19th century. One of the hit songs then was what they call Radium Dance, and you could see, all those, shall I say, stars around that, just buttressing the fact that radium decayed with a particular glow around it. And the title of the song then was Piff Puff Poof. One of the other best-selling instruments then were radium-coated wristwatches. And that had a particular significant historical, history behind it. Another interesting advert then was these hair products that says 65 and never a gray hair. So that was radium in the hair product. Now, unfortunately, despite the fact that society really embraced radium, within a short while, they began to realize the potential implications of excessive radiation exposure. Now, these girls here were the popular radium girls that were tagged the living dead. These were teenagers who worked in the wristwatch manufacturing company, and what they had to do was quote the numbers on the wristwatches with radium. They used brushes that had to be very, very fine tipped, and in order for them to make sure that it's pretty precise, they were encouraged that once they dip it into the radioactive source, they then make it into a fine point by twisting it in their mouth before each quote. Now, within 5 years, now they were paid very well. Within 5 years, most of them developed cancers of the jaw, hematological blood cancers, aplastic anemia. And then they realized that, well, I think this is all work-related. They then sued the watch manufacturing company, who, in defense, argued that these teenagers had syphilis, and it had nothing to do with radium. Now, one of the patients, before she died, reenacted exactly what she did. Putting the paintbrush in her mouth and said, "I did these thousands of times." The good thing was that they won the case, settled out of court. But most of them were dead within 12 to 24 months. And after this case, there was a lot of public awareness that maybe radium is actually not the magic bullet. And then over time, there were lots of precautions and legislation guarding against radiation. Now, as part of radium, Rutherford, who is, I discovered yesterday that is actually from New Zealand, discovered the concept of alpha particles back in 1898. So he realized that they were 8,000 times larger than beta particles. And some interesting characteristics about alpha particles is that, number one, they travel just within a very short distance in tissues, so just about 2 to 3 cell layers thick. They had a very high linear energy transfer. And biologically, what this means is that they're actually able to cause cell damage and cause double-stranded DNA breaks. Now, DNAs are two-stranded. Now, if you cut one of the strands, there are processes in place that will repair that single strand break. So, in order to induce apoptosis or cell death, the better way to go is to actually cut the dual-stranded DNAs. So one of the very important clinical benefits of alpha particles is that if we can get them close to where they're needed, they will cause cell death. Now, there's been lots of work done around the potential clinical use of alpha particles. First publication was back in 1999, and the first patient was treated back in 1995. Now, we're talking about probably 20-something years later, and this treatment concept is still not yet mainstream for multiple reasons. So that just buttresses the fact that alpha particles, which is the focus of this talk, will be stopped by just a layer of paper. Now, radium-223. So radium-223, it's an alpha emitter. It can be produced from nuclear plants or from a actinium-227 generator. It has a half-life of 11.4 days, and it emits 4 alpha particles. Alpharadine was developed by a Norwegian company and also with Bayer Pharmaceuticals. And one important clinical characteristic of radium-223 is that it has a natural affinity for bones. So if it's injected into the human body, it specifically just goes to wherever there are bones within the body. And this is what, this is the property that was utilized in designing the clinical study that I'm just going to talk about now. Now, radium-223 is in the same group as calcium. Now, most of the bone is made up of calcium. Strontium is another radioisotope that we've used in bone pain palliation in patients with metastatic prostate cancer. And that's radium down there. I'll just keep that slide. Oops. All right. So how does radium compare to other radioisotopes we've used? So strontium, samarium. Now, both of these radioisotopes have actually fallen out of favor. Part of that is they are beta emitters. They travel a longer distance, so they cause more toxicities. And that's just a quick caption, a quick image explaining the fact that once radium is given, it produces a localized effect. So most of the other surrounding tissue, the bone marrow, are all protected from toxic effects. Now, in clinical medicine, randomized controlled trials have the highest level of evidence. Especially in medical oncology, most of what we do is based on solid data. So RCTs are so important before we expose people to, potentially detrimental um, um, chemicals. Now, the phase 3 evidence behind the benefit of radium-223 in patients with prostate cancer was called the ALSIMCA study. Now, another interesting thing about oncology trials is that we come up with all these very fancy names. So ALSIMCA study, which is alpharadine in symptomatic prostate cancer patients. So the inclusion criteria of patients who will be eligible to participate in this study must have symptomatic metastatic prostate cancer. They must have evidence of bone metastases, and they must either be unfit for chemotherapy, that's docetaxel, or they must have progressed after docetaxel. And then they were stratified based on some other parameters. Now, divided into two different groups. One of them had radium, and the other had just best supportive care. Now, people were excluded if they've had chemotherapy in the previous 4 weeks or recent history of radiation therapy or any other radioisotopes in the previous 6 months. And the outcome of this study was how long people lived for after radium treatment. Other endpoints included total alkaline phosphatase, which is a blood test, and also time to their first symptomatic skeletal events, which could either be an unprovoked fracture or requiring orthopedic surgery, or if they required increasing pain medications. An interesting thing was that people who had radium-223 treatment actually lived longer, so that was the green line. So they lived longer compared to those who had just best supportive care by about 3.6 months difference. Now, in terms of time to first symptomatic skeletal event, we also know that people who were treated with radium-223 had a longer time before they had their first symptomatic skeletal event. Now, looking at the forest plots, literally everyone benefited, apart from those that had probably less than 6 mets in their bones, or those who were already pretty frail and weak. That's ECOG of more than 2. And then those that had what we call a super scan, which is quite a heavy burden of disease. Just a quick case study about a patient that was treated with radium-223. So he was diagnosed with a T3N1 prostate cancer back in 2006. He had a Gleason score of 9, and he had extracapsular extension. So all these are pretty, shall I say, poor histological features. So looking at this, histological findings, we know that this person is going to do a bit poorly compared to those that had a lower Gleason score, for example. So he had surgery, had radiation treatment, had some hormonal manipulation. After a couple of years, he progressed. And then in 2010, he had evidence of bone metastases. He subsequently went on to have chemotherapy, and then had more chemotherapy, and then had palliative radiation treatment. And subsequently, back in 2014, there were new medications that came onto the market, abiraterone and enzalutamide. He had those ones as well. He had some response for a while, and then had progression of his disease with worsening bone pain, multiple bone metastases. And at this stage, he had very limited treatment options. And if you look at his PET, his bone scan there, there is obviously extensive evidence of bone metastases. Now, radium-223 is an option for this man because, looking at the ALSIMCA study, he will actually fit into the category of people that would benefit from radium-223. Now, the main problem here is that we know it works. It's been approved by TGA, but it's not available. It's available, but it's not being paid for by the government. For those who could privately fund it, they can get access to it. So this man got access to radium-223, and after about 3 treatments, didn't have any significant response to radium-223. His PSA kept on rising, his ALP kept on progressing, and the decision was made to stop the treatment. Now, basically now we're at a crossroad. So we know that there is a phase 3 study that said, well, radium-223 helps. We know it works, but unfortunately for this particular patient, it appeared that it did not. Now, after that initial publication back in 2014, there have been more studies done. There are more data coming out. And most of them, they're not level 1 evidence, they're not randomized controlled studies, they're usually retrospective studies or exploratory analysis. But they're all hypothesis generating. Now, one of the abstracts published, I think 2 years ago, was that the group of Noel Williams looked at the effect of duration of treatment on the survival of patients. Now, I won't bore you with all these stuffs, but what they looked at is, was there an optimal length of treatment of radium-223 that actually had maximal effect on survival? And they found out that people that had 6 injections of radium-223 actually lived longer, about 12 months, above those who had less than 6 injections. As I said, this is quite limited in terms of scientific rigor because it's a retrospective data. Another study looked at, very similar to the previous one, that, people who had up to 6 treatments compared to those who had less than 6 treatments. How do they compare? Now, we know that those who had about 1 to 4 injections had a median overall survival of 6.3 months, while those who had 5 to 6 injections lived for, now that's median overall survival, so about 50% of them will live for at least 18 months, while those who had less than that will live for probably about 6 months. Now, this is also limited because it's an exploratory analysis. Now, if you remember one of my previous slides, I talked about how when a study is done, we start at the very tail end of the curve and then gradually move the evidence backwards. So this is a phase 1, phase 2 clinical trial that looked at the effect of combining radium-223 and docetaxel actually very early in the disease. Combining docetaxel and radium-223 versus just giving docetaxel alone. And the parameters they looked at were bone markers. And what they found out was that there was a greater decline in the bone markers in patients that had radium-223 and docetaxel compared to those that had just the chemotherapy alone. So this is kind of like a signal that yes, we can combine radium-223 and chemotherapy safely, and our patients potentially will do better if we're able to combine both. But can we generate any significant conclusions to change practice from this? No. It's a very small study, and it requires the hypothesis to be tested in a larger clinical study. So this is pretty similar to the previous ones I've presented. Now, in the Alsimca study, they looked at patients that had symptoms. Now, this study looked at patients that did not have symptoms, and they compared them to those that had symptoms. One of the things they found out were that people that did not have symptoms were more likely to complete the 6 cycles of treatment, and they had lesser side effects compared to those that were symptomatic before they were treated. Now, in order to test all these hypotheses I've described, there are studies currently ongoing, the ERA 223 study and the PEACE 3 study. I told you oncology has these very fancy names for clinical trials. That's actually just confirmatory of that. So all these are looking at the benefit of radium-223 very early on in the disease. Now, over the next few years, there will be data coming out actually confirming or refuting these hypotheses. Now, what are the future directions? We know that radioisotopes have immense medical and potential oncology benefits, or shall I say treatment benefits. There will be more developments in the area of radioimmunotherapy, trying to utilize the radiobiological properties of ionizing radiation, in addition to monoclonal antibodies or even immunotherapy, to try to increase in a synergistic way how the body's immune response to fight cancer. And one of the key players, or one of the potential key players in this domain, is going to be alpha labeled radioimmunotherapy, because this is particularly indicated in patients that have very minimal disease, patients that have micrometastatic disease, or even in hematological cancers. Now, there have been some drugs approved in this particular domain. There is Bexa, and there is another drug now, I can't remember the name, which had very good clinical outcomes in people that had refractory lymphoma. Now, the logistics of administering these products, the complexity of actually even compounding them, makes them very difficult to use. And one of the products was pulled by the pharmaceutical company a few years ago because it was literally just impossible for them to get them to patients. Now, another interesting area is the domain of what we call theranostics. So theranostics is a concept where we use a ligand or a tracer to image a particular tumor. Now, the ligand has to be specific for that tumor. And then we take the same ligand, we attach a linker to it, attach a radioactive payload to it, and then use that same ligand as a treatment strategy. And currently, in the domain of neuroendocrine tumors, there is an increasing use of lutetium dotatate to treat neuroendocrine tumors. And over time, we're going to see lutetium labeled with PSMA also for therapy. Now, just for me to round up this talk, this is an interesting front page image on Journal of Nuclear Medicine, I think last year. Now, this patient had significant burden of disease. He had prostate cancer. He's failed virtually every treatment, and he's progressed on 2 doses of lutetium PSMA. Now, the power of the alpha emitters, the power of the alpha therapy. After 2 cycles of actinium, which is another alpha emitter labeled to PSMA, his PSA results dropped from 419 to 3.5. He had 1 more treatment, and his PSA was unrecordable, 0.1. Now, does this mean much? Yeah, it's probably a signal that there are unproven benefits that we could get if we are able to harness the power in alpha emitters in managing some cancers. And I'll leave you with the final words from Ernest Rutherford, who said an alleged scientific discovery has no merit unless it can be explained to a barmaid. Now, most people, when they hear radioisotopes, are scared. And when people come in for sestamib and I tell them, oh, we're just going to inject a radioactive tracer, they look at me. I could see that puzzled look on their face. And that's because bad publicity makes the news. So when excuse me, when somebody gets killed from radiation poisoning, like the Russian spy, that makes more news, and that helps to shape people's thinking. But we have to be able to explain, as we will explain to a barmaid, the potential benefits, and not just to the public, but even to the regulators as well, that there is immense benefits medically in rational radioisotope use. Thank you.
Thank you, Addie. Have you got any questions at all? Okay, that's for you as well. Thank you very much. Just a few more formalities this evening. I've got some clinical awards for some CSU students, one of which can't be here tonight, but I think Brendan Mulcahy is here to accept his award for recognition of the best performance in clinical subjects at CSU. So if you'd like to come down. Newcastle, sorry. Sorry, and the other winner for Charles Sturt University was Madison Barton, who can't be here this evening, so congratulations to Madison. So just a reminder, our next meeting is going to be held on the 19th of July with a venue to be determined. Mind you, we've volunteered St George Hospital, so pencil that in your diaries. Also, the Rad Farm Award will be done at the Hunter Tech meeting in September. So as we said before, the deadline will be the 1st of September. So keep an eye out for some interesting studies. We need as many presenters to represent New South Wales as possible, so look out for some good presentations. The prize, if you present at the Hunter Tech meeting, you'll be given $50 from GMS just for presenting, and then the winners will go on to present at the NSWSNMS, where you'll have your registration paid for by GMS. So with that, I'd like to thank our presenters this evening. To Addie and Kirk, thank you so much for your presentations. They were very insightful and entertaining. To University of Newcastle, thank you so much for having us. And obviously to the guys from the John, thanks for organising everything this evening. And we'll see you soon.